Hey everyone. Thank you for joining me on today's episode of Conversations with Julia Craven. I'm Julia, and we have with us Dr. Chambers, a certified, sorry y'all, OBGYN, and we are here for a discussion on Black women's reproductive health. And next week I'll be back to, talk to someone else. But today we're going to talk with Dr. Chambers. How are you?
I'm doing well. Thank you so much for having me, Julia.
Of course. Thank you for joining. So let's just hop right into it. Tell
Yeah.
our viewers a little bit about yourself. Where do you practice? What do you specialize in? Who are you?
I'm Dr. Charis Chambers. I'm a board certified OBGYN, and I actually just completed my fellowship training at Baylor College of Medicine in Houston, Texas, in pediatric and adolescent gynecology. And what that looks like is a lot of kind of counseling and education, more minimally invasive approaches. When it comes to younger girls, so girls that are 21 and under, but also a full, training and understanding of women's health as it relates to obstetrics and gynecology across all age spectrums as well. I have started an Instagram platform called ThePeriodDoctor, where I do a lot of medical education and advocacy there as well. I'm currently about to start practice and joining my dad and brother, the other Dr. Chambers, who are also OBGYNs in Columbus, Georgia. So I'm very excited about that. I'll join them in the fall.
Wow, that's so exciting. I didn't know. So y'all are just like a family of OBGYNs.
Yes. I like to call it an OB dynasty, but literally they never say that. I'm the only one that says the dynasty part. I think it's clever, but
I think it is too. I think it's cute. And so what made you want to go into medicine, and specifically what made you want to follow in your dad and your brother's footsteps and be an OBGYN?
So I actually have always loved science and math. My dad, who's really a great surgeon, would send me kind of pictures of fibroids and other tumors and things that he'd remove. And there'd just be like
Mhm.
pictures, and I'd be at lunch at school. I'd be like, "This is so great." And my friends would be like, "You're so weird." So I knew that there was something about me that was kind of drawn towards surgery and medicine. And then I attended
Mhm.
Spelman College, which was an amazing experience that really prioritized like servant leadership and advocacy. And so I was drawn to advocacy for women and children when I entered medical school. So at that point, I was like, I want to be a doctor. I want to be a physician. When I entered medical school, I just loved OBGYN. I loved taking care of women. I loved taking care of menstruators. I loved kind of navigating these times of life and really educating and partnering with a patient who could be potentially very vulnerable, but who really needed sensitive and comprehensive and compassionate care.
Wow, that's lovely. My goodness, that's so wonderful. So let's just hop right into it. So what are some of the issues that affect Black people reproductive wise?
Oh my goodness. So when you really think about it, we can kind of start from time of birth until like you get later on in life. And so if we're talking time of birth, as in this is the woman, the patient that we're talking about, Black women and are much likelier to have, well, fetal demise, premature birth, so premature deliveries. And with prematurity, there's a ton of issues and aspects that can impact your hearing, your cognition, your overall function. And so that's earlier life. When it comes to like puberty and those time periods, we know that Black girls are going to they start their periods about 6 months earlier than their white counterparts. Throughout kind of those reproductive years, we have issues with fibroids, higher risk of cervical cancer, higher risk of breast cancer deaths, all of these issues that are just constantly navigating. You throw in a much higher risk of maternal mortality, which as of now is
Mhm.
about 2.5 times the rate of our white counterparts when you think about Black women and their risk of death. And that's as recent as the 2018 data that came out in January 2020. Previously, we thought it was about 3 to 4 times higher, but we know that the more recent and more standardized data shows 2.5. And then there's also higher
Yeah.
risk of infertility, decreased likelihood of getting fertility treatments, a higher use of mammography, but more aggressive breast cancers. And so all of these things, there's so many that really
Yeah.
negatively impact Black women reproductively throughout their lives.
Right. And so why is that? What is it? What are some of the risk factors? Why does the data show us
Right.
this?
So there's a number of ways to assess some of the things that contribute to this. So there's some kind of patient-centered causes. So yeah, as a population, some Black women may be a little bit more hesitant to utilize, medical services, and that has a lot to do with systemic oppression and historical and medical crimes that we can read about for decades and decades.
Right.
That really can promote some hesitancy and strain on that doctor-patient relationship. There's also provider kind of centered issues where there's implicit bias and racism structurally there, just not listening to Black women. I mean, like prevalent, rich, like it doesn't matter how educated they are, how well known they are,
Right.
how many television sets they're on, internationally,
Right.
they are, just not listened to. There's also just kind of the more systemic aspect of the systems that are in place, food deserts, lack of access, being uninsured, underinsured. There's so many pieces. And then there's a bit of a genetic piece. The genetic piece that we're kind of unpacking a little bit. Yes, there's genetic susceptibilities to things like sickle cell. So that's straight up, going to be something people of African ancestry are going to be higher, risk or higher predisposition to. But then there's other things like the collective strain of racism and what that does to your DNA and how it's actually incorporated into your DNA through a process that people are calling weathering. And so there's so many things and so many pieces, but we know that it's not just explained by education and even those comorbidities of like more obesity or diabetes. There's so many layers to it, and that's why it's such a big issue.
Right. And so in terms of when I was listening to you, I was thinking about how these issues get covered in the media and
Hmm.
how even well-meaning reporters sometimes they
Hmm.
kind of just boil it down to Black women are more susceptible to this. And they
Correct.
don't really go into why that happens. And so I wonder if you could touch on, how dangerous that is when we're trying to
Oh,
talk about Black women and Black women's health.
absolutely. So one of the things that bothers me most is, the Black race is a risk factor for it's just like no, 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 no. Racism
Yeah.
is the problem,
Yeah.
and like, oh, being a woman puts you at risk for no, 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 no. Sexism is the problem. And so
Right.
when you're verbalizing these things and you're suggesting that by being a Black woman I am in this like negative place, it really it scares Black women, number one, but it definitely makes it harder to search for solutions when you feel like you are the problem, right? If someone's painting, Black
Right.
women are the ones who die, it's like, no, is it possible that the medical system fails Black women at a higher rate? And that's true. We know that a
Right.
lot of these deaths are preventable. And so there's a failure to Black women. And, it's like, Black men are more likely to die by the bullet of a police officer. No, the police are more likely to shoot them. That's
Right.
the narrative that needs to be said. I know that that seems inflammatory, and that's possibly why reporters kind of teeter or even kind of use these euphemisms and things to make it just seem a little bit more palatable to a larger audience. But sometimes things don't need to be palatable, right? If it makes you uncomfortable to know that I'm more likely to die, can you imagine how uncomfortable it is for me to know that I'm more likely to die, right?
Right.
So I really I would
Yeah.
love it when reporters are able to be more thoughtful in their word choices, to call it what it is. And it's a failure. It's a failure for Black women, and we have to do better.
Right. Absolutely. I'm very glad that you come at this issue from an instance. I just to go into my own experience because it would. I mean, I'm a Black woman. I probably should talk about my own experience a little bit. I have encountered a lot of physicians where they just don't come in from that angle. It's very much, well,
Mhm.
what are you doing? What are you doing wrong? And
Yes.
also not being believed when I say
Mm.
that something is happening with my body or that something is off.
That happens. I mean, I hear so many stories. There's so many stories of that. And the trouble is we're fighting a few battles here. I think as Black women, we don't want to come across as difficult or aggressive because media already paints us as that, right? So it's a
Mhm.
lot more agreeable for us to just kind of go with the flow and try to say, you know what, I'm going to trust that doctor. But we have to
Right.
learn how to advocate for ourselves. Not that it's our fault that they're not listening, but when we recognize that or we suspect it, we must stand up. We absolutely have to enter into a space where we are going to advocate for ourselves. And it's hard. Is it annoying that we have to advocate that much more or say something 3 times before it's heard? Yes. But if your
Yes.
life depends on it, I think most of us would go ahead and say it those additional 3 times if it's going to mean the difference between my fertility and not, or a healthy baby or not. And so that's hard, but I just want more Black women to be empowered to do so. I want them to say, you have the right to have a doctor that listens to you, and you have the right to call them on it.
Right, absolutely. And so how would you advise that Black women do that? Because I know well, I've always been a bit of a loud mouth, so I've
Mhm.
never had a problem shouting when something was wrong. But but I do know that a lot of people just have deference for doctors, understandably so,
Mhm.
because doctors are brilliant and they save lives, and all of this is true. But I think that's a twofold issue. We can take humanity from doctors because they are doctors
Right.
and they are, in fact, heroes. But when we paint people as heroes, we tend to look past their faults even when they affect us.
Right.
So, how would you advise Black women to advocate for themselves?
Mhm. So the specific things I like to tell Black women, one, your doctor is a human, and I want you to see me as a human. I want you to see me as a person who needs sleep, deserves respect, and is navigating this life trying to be healthy and trying to be fulfilled and just have a good quality of life just like you. So, the trouble is when we paint doctors as heroes, we sometimes diminish the humanistic sides and kind of hold them to a standard that's one impossible to maintain, want access to them all the time, which is detrimental to their peace. And so I think acknowledging the human nature of doctors is huge, hugely important. And when you do that, my hope is that you can um, enter into that partnership, that patient doctor relationship, understanding that your role is just as important as mine, if not more important. And so the things I tell my patients to do, write down your questions. And I want you to write down what you're hoping to leave the visit with. So if you're going in and you're in pain and you're like, I need this pain to be under control so I can go to work, you ultimately want to leave that visit with something to help your pain. The longer term goal may be the diagnosis, understanding it and managing it, and maybe getting some more definitive
Mhm.
treatment. But in the meantime, you might need something to manage those symptoms. And do your best to not leave that office visit until that's addressed. Because you can get distracted throughout the visit, and say, oh, I'm going to get an ultrasound and do all that. Okay, I'll see you later, Miss, whatever Johnson. And you're like, man, but they didn't give me something to help with my pain. And I'm still needing this
Right.
to return to work. And so I start my visits by saying, I understand that you're here for this and we're going to get into that, but I need to know, what do you want to leave here today with? You want a diagnosis? You want to start getting some answers? Do you need medical therapy? Because I know no matter what I do, even if it's protocol based and I'm following all the things that I typically do, if I can't meet you where you are, where your needs are, I have missed my opportunity to best serve you. And so I think understanding that up front is important. And then when people don't listen, when they blow off a complaint, bring it up again and say, but I need to know why. I need to understand why. What are you doing
Right.
to look into that? I've done that myself. And I was called difficult. The the specialist said, you like being difficult, don't you? And I was just like,
Wow.
I mean, and I was a resident physician at the time. And that's just one of the things we have to be able to deal with. They might not like it, but it's their job. And most importantly,
Right.
get a second opinion. If you don't feel good about something, especially an irreversible thing, a hysterectomy, any type of sterilization procedure, anything that's being, permanently removed, make sure that you're getting a second opinion. Good doctors are not offended by second opinions because they want their patients to feel comfortable about the plan. And if my colleague can tell you, Dr. Chambers was spot on, she did A, B, and C, I would do the exact same thing, then I know that your trust
Right.
is going to be that much stronger. And now we can proceed with you feeling that much more confident in the plan. So those are some of the things I tell my patients to do.
Absolutely. And so I'm trying to look at my list of topics here because we've already covered so much. And
Yeah.
and so I do want to dig in a little bit deeper about advocating for certain treatments that weren't offered
Mm-hmm.
to us. Because I know I have been in a predicament where I go into a doctor's office and I'm just like, hey, I know I've been in here a few times, but like I saw this treatment that apparently works for a lot of people. And like I'm
Mm-hmm.
wondering if it's something that like an IUD, right? I'm just like, well, I've been doing my
Yeah.
research and I want to know what you think about this one because maybe that wasn't necessarily offered the first time I came
Mm-hmm.
in for endometriosis. Thankfully that didn't happen to me, but it was the
Yeah.
example that came right to mind. So what would you say about that? Because that's just a lot of labor to have to do that research as a
It
patient.
is. It is, but you must. You absolutely must. And there's some good reputable resources. One of the resources I like is youngwomenshealth.org. The CDC is a great resource. Make sure
Mhm.
you're looking at reputable resources. But the more you know, the more you're able to kind of pick out that doesn't quite sound right. I know that there's more than just a hysterectomy. I know that there's more than just taking out my
Right,
ovaries. I know there's more than just narcotics, right? Um,
right,
Now, one would hope that a physician would be able to go through, these are our non-hormonal, these are our hormonal, these are our definitive, this is most invasive type of thing. You should be able to give the full range of things, but there's certain limitations. Physicians are limited by one, their training and what they are actually exposed to and what they know. Two, what they're capable of doing. Three, what their access is, to. Maybe that hospital doesn't have a robot room where they can do like a robotic procedure or some minimally invasive approach. And so,
mhm,
it's appropriate to say, is there anything else? Is there anything between hysterectomy and ibuprofen? Yes, there's literally like 30 things in between those. So if someone's just saying, girl, you can take some ibuprofen, I can give you Depo, or you can get your uterus out, that is wrong. So,
yes,
if you don't have a method that fits you well, that fits all of the things, as in, I'm not ready for kids now, I want to prevent pregnancy, but I want to be able to have kids in the future, but I want my pain under control. There's a method for you, and it needs to be tailored to you.
yes.
And if we're not hitting all of those things and you've identified them as like sincere, significant priorities, ask for more.
Right. And what would you say to people who get frustrated by that process? Just to stay
Yeah,
in the same vein of finding a birth control, that is a that can be a long process
it
to find
certainly
something that
can.
works.
It certainly can. So there is no magic test to, for me, even as a practitioner, to predict how someone's going to respond to birth control. Really, every person is different. And even if it works for 90% of the people, that 10% is going to need to try some other methods. And so there's a bit of partnering and patience when it comes to finding exactly what fits you. But when people are frustrated, and it's about the same thing as the frustration of buying a house. Like if you just pick one realtor, they're gonna be like, yeah, all the houses are 500,000 and above, right? If you're like,
Yeah.
that doesn't sit well with my bank account, right? You have to
Right.
make decisions that feel good for you and that maximally meet your priorities and what you're hoping for, as relates to the life that you see for yourself. When you're not hitting those, you can get frustrated and say, you know what, I don't want to put in the work, but you're only letting yourself down. And that's kind of what I tell women. Like, if you're not satisfied with this, it's going to take some work on your part. It can be the work to find a better physician so you do a little less research on your own time and someone that you trust, or you're going to have to step it up to do that research so that you know exactly what questions to ask and what to kind of bring to the table, because it's a partnership. It's certainly a partnership. And so if there's a deficiency on one side, it's going to have to be made up on the other side. And so I'd love for people to find exceptional physicians that just, present everything to them perfectly. But again, a bunch of humans, and there's going to be variability in that approach.
Of course. And so fibroids, I do just want to, and I will just let you go and talk about fibroids, and then I'll just kind of
Yes.
hop in, because I know personally so many Black women who struggle from
Oh,
fibroids.
so many, so many. So,
Yeah.
July is Fibroid Awareness Month, so this is a very timely kind of topic. But fibroids are essentially benign growths of the muscle layer of the uterus. They can vary in size, and they tend to start to arise around the age of 30 or so, and then get progressively more prevalent with age. Women of all races have fibroids at about 60% of women are going to have them, but Black women have it at about a rate of about 80%. Black women are also more likely to have larger fibroids and are more likely to have issues like anemia and have to undergo a hysterectomy for fibroids. Fibroids can be debilitating. They can be so big that you can feel, third trimester pregnant. In those scenarios, they can lead to issues with excessive bleeding, so much so that you can be anemic. And anemia is when you don't have enough red blood cells around, with red blood cells being those cells in all of the liquid, the plasma that's in your blood that carries oxygen. They're critical to your survival because they go to all of your organs, your kidneys, your brain, everything, carrying that oxygen. When you don't have enough, your heart pumps faster. And so it can even lead to heart failure if anemia is not corrected. You can feel super tired. You can have a ton of other downstream effects from profound and prolonged anemia. And so, fibroids have major, major issues, and they're a major burden to Black women. And so what that looks like is, one, painful periods, issues with fertility, issues with just quality of life, more depressive symptoms, more constipations, issues from a GI standpoint. And then, of course, the higher risk of major invasive kind of procedures. Transfusions are not benign, and even, up to hysterectomy. So it's a big deal for a lot of Black women. And the issue is not everyone knows to look for it. There's some Black women who just think in their family they have heavy periods. No, in your family, you have fibroids, and if you don't talk about it, and if your grandmother never told anyone why she had her hysterectomy at 40, and your mother never told anyone why she had her hysterectomy at 35, it's not one of those things that we're aware of, and we think we're supposed to bleed like that. We think we're supposed to feel like that, and we're not.
Yeah. So first let's talk about what treatment options are available for people who have fibroids. And then I do want to get into Black families not talking about this stuff.
That's huge. Okay. So the treatment options available for fibroids, they really center around, well, one, what are the symptoms? So there's a number of people who are walking around with tiny fibroids, don't know it, will never need anything, to do anything about it. And so if the fibroid isn't bothering you, you really don't need to bother it. It's kind of the school of thought. If it's very small, you're not having pain, you're not having excessive bleeding, I'm not going to, enter into your pelvis and remove something that's not bothering you. And so that's, there's a watch and wait component there. There's certainly a potential for using like non-hormonal medications. There's your ibuprofen, things that can help with the pain and bloating from fibroids, and ibuprofen can sometimes help actually decrease some of the bleeding. There's medications like antifibrinolytics that help with bleeding as well. They're not hormonal, you only take them during your period, but they can help decrease the overall blood flow. Then we have our hormonal medications, our typical birth controls, because they do decrease the amount of bleeding that you have on a monthly basis. And that can be super helpful for someone who just has the anemic kind of symptoms without the bulk symptoms of like a full belly of fibroids. There's things like a uterine artery embolization, which is literally where you block the blood flow to the uterus so that you bleed less. Sometimes that can lead to shrinkage of fibroids. There's some sonographic procedures where you can actually radio ablate the fibroids themselves and kind of literally destroy them. There's removal of the fibroids themselves, via minimally invasive approaches. And then there's a more maximally invasive, like an abdominal myomectomy. I'm kind of making a C-section incision on your belly, removing the fibroids that way, sewing the uterus back up. And then, of course, at the end of it all, last, there's like hysterectomy. There's a few other things in between that, but ultimately those are like the overarching categories of treatment options.
Wow. And so to get back to families not having these conversations, because I had really heavy periods when I first started having my period, and it was never, I think, I can't remember which family member said something, but one family member was just like, whoa, like, this is not, like, we need to do something. Like, she needs to go to the doctor. Like, this is not, like, these heavy 10-day periods. Like, whoa, like, that's not normal.
Yeah.
But But if I hadn't have had that,
Would you
I just
ever
would have
know?
walked around thinking that, right, like I probably wouldn't
Right.
have known. So what is the it's obviously so important that families have these conversations with one another, but if an
Mhm.
elder in a family is hesitant, how would younger family members who have these questions about fibroids, heavy
Mhm.
periods, do we like do you have endometriosis? Did you have any
Right.
issues during childbirth?
Right.
How do we initiate that conversation?
So that, I mean, that's a huge factor. And that's a large reason and a bit of the impetus behind me creating the Period Doctor. I really wanted there to be a resource for Black and Brown menstruators to look at something and say, this is what a doctor says, and explain all of the things that we as physicians have failed to explain for many years. We've just failed to explain it. We assume that people know so much, but when you don't know that, you're not going to initiate that conversation with a younger relative because you don't know what you're talking about. You're like, a period's when you bleed. It can be, this long. It probably shouldn't be more than 2 weeks. You're just throwing things out there. And it is a normal human trait to not talk about or engage in conversation on topics that you don't understand well. It's normal to have a fear and a little bit of an aversion to things that confuse you. And so part of what my goal is to break generational cycles of misconceptions. I remember when I got my period, my mom told me kind of what it was, and she was like, okay, you got your period. This is what you're going to do. Make sure you throw your stuff away separately, and no one should ever know when you're on your period. What she was trying to say was, hygienically, we put things away. We don't make a big fuss about it. We just continue to push through life. But what that tells me is that we shouldn't be talking about it, right? Luckily, I didn't have problematic periods, but my two sisters did. And it took them a while to figure out that they were abnormal. Some people will just be like, I just pass out in the shower on my second day. And I'm like, that's not normal, right? I can't
God.
go to school on day 2 and 3. Also not normal. I bleed for
Right.
10 days. Not normal. And so a lot of it's setting
Right.
out parameters for what is normal so that you have a launching point on which to talk. And so I try to tell parents of young girls, have a check-in. When you've started periods, we need to check back in. Because I had a patient whose mom would just put pads in a cupboard and just refill it and not speak with her daughter about it. It was just like, hey, you take care of your period, that's your thing. Her daughter bled for 3 months and came into the 3 months straight just using pads because she was just like, I just use a pad when I bleed. That was kind of the thing. Came into the hospital, needed multiple units of blood because she was so anemic. And the mom was like, I wish I would have talked to her. So the point is, you have to engage.
Yeah.
Engage in the conversation. Say, do you think you're bleeding too much? And you need to have a parameter for that. Do you think you're bleeding too long? Have a parameter for that. And if your child is missing school or work, that is not normal. And take them to a doctor to be
Yeah.
evaluated. So it's not easy, especially when you don't have the framework and the education to start those conversations. And so for anyone who's interested, go over to my page. I try to talk about a number of different, aspects of periods and pain and all of these things that are super important that we've never had conversations about enough, in my opinion, especially in the Black community.
Yes, and her IG page is great. I can certainly confirm that. Um,
Thank you.
yeah, it's just periods are a trip, truthfully,
They
because
are. They
even
are.
when I got my diagnosis for endometriosis, I was just like I went to the doctor because I was at home for Christmas one year, and I noticed that I was taking ibuprofen every 6 hours, but nothing was happening.
Oh goodness.
And
Yeah.
I was just like, whoa, like, what is, like, why am I not responding to this? And I mentioned it to my mom, and she was just like, oh, go to the doctor. Like,
Hmm.
don't just wait around. Don't just be like, oh,
Oh,
well,
I'm glad she said that.
maybe it's this. Like, no, my mom is a big fan of go see somebody. She
And
told me
that's
once when I
awesome.
was younger, she was just like, because she's a very religious woman, and she was just like, Jesus isn't here healing people anymore. So God gave that knowledge to doctors. So my family is very big on go to the doctor and make sure that you're
I
all right.
love that.
Um,
Yes. But there are a lot of families that are,
so
and they're not informed. So you don't have the information, and your family does not trust
right,
doctors. And so you're really in a bad place there,
right,
So yeah, we've got to do better.
right, absolutely. And so I'm trying to see if I have anything else to ask you. We've covered so much. Yeah, wow. I think we got everything. Impressive.
Awesome.
And so we do have a few questions.
Okay.
So the first one is, when is the average starting age of perimenopause?
So perimenopause is basically the time around menopause, is what we call it. The average age of
Mhm.
menopause is 51, and that's in the United States. And perimenopause actually can last about 10 years. So it kind of
Oh,
depends. The
wow.
average age of menopause is more specific and definitely easier to kind of lay down. But we know that even in your 30s and 40s, your estrogen release from the ovaries actually starts to fluctuate, and there can be changes to your periods that are kind of leading you towards menopause, with perimenopause being more acutely around the menopause time period.
Okay. And another question that we got is, are irregular periods a symptom of fibroids, such as when you do not have a period for a couple months, but you know for a fact that you're not pregnant?
So fibroids typically are not changing the frequency of periods because they're not hormonal. So hormones are the ones that kind of say when we're going to have periods occur. But fibroids tend to make periods significantly heavier. So they're typically occurring at the same time, but they're heavier and more painful. So no, absence of periods or infrequent periods, as that question is asking, is not a typical symptom of fibroids at all.
Gotcha. And so, what is considered a normal period, or is there a such thing as a normal period?
There certainly is. And when we're saying a normal period, we mean that 95% of women are going to fall within these parameters. So, what that looks like for adolescent girls is a period every 21 to 45 days, lasting 7 days or
Mhm.
less. For adult women, it's a period every 21 to 35 days, lasting about 8 days or less.
Got you. So, what is the 10-day difference? What is that about as far as
Well,
average
yeah,
cycle length?
that's a good point. So, when you're starting your periods in adolescence, your brain, um, the hypothalamus has to, and the pituitary and the ovaries, all of these have to kind of sync up. It's called an axis, and they have to kind of synchronize. And so when they're not quite in sync, we say they're immature. And over time, they become more mature, and your periods become more regular. And so the range actually gets tighter.
Gotcha.
Okay.
Okay. And I have a question about regularity. Should people who have periods, should we be, obviously, we should be on the look for anything that is very clearly off, but
Mhm.
how do you determine when something is wrong versus this is just a regular period for me?
Yes, that's a very good point. So irregular periods, really for anyone, are going to last longer than 8 days. Irregular periods are so painful that you're missing work or school. You're changing a period product one every hour for more than 2 hours, and that's a period product that's appropriately suited to you and your flow. And then an irregular period is like, oh, if you're going without a period for longer than 45 days, that's too long. If you're having, periods more frequently than 21 days, that's too frequent. Those are kind of the best ways to kind of say this is what we need to be looking for.
Gotcha. And so, are there any resources for teens and women looking to educate themselves?
Certainly, certainly. One of my favorite resources is youngwomenshealth.org. That's an awesome one. Um, let's see, bedsider.org is a good one for contraception. And then, of course, the
Mhm.
CDC is a great one as well. ACOG, the American College of Obstetricians and Gynecologists, has a patient frequently asked questions page that's super, super helpful too.
And do women get more ovarian cysts in perimenopause compared to before perimenopause?
So, not necessarily. Ovarian cysts, there are a ton of causes of ovarian cysts. A lot of the times you're going to see ovarian cysts occurring at time of like ovulation in an ovulatory woman, but there's also abnormal ovarian cysts, and then there's even cancerous ones. Um, Cancer is more commonly seen when you have an ovarian cyst in a woman who's gone through menopause. We're more concerned about cancer. There's not necessarily more ovarian cysts in that perimenopausal state.
Gotcha. And is 13 too early for birth control when trying to regulate a period?
I love that question. So we actually give birth control methods to anyone who has a period. It's not too early at all. And the reason I say that is because it's not that we're saying 13 is not too early for intercourse. We're saying for medication to regulate a period. The term birth control is a bit of a misnomer in the sense that it is utilized for birth control, but we're using it to regulate the period. And because period regulation and frequency is determined by hormones, hormonal methods are the most effective. And so it's not so much that we're giving a child birth control, it's that we're treating a patient with the appropriate medication. And so 13 is not too early. The earliest really that we've given it to young girls is about 9, because 9 is like the earlier normal start time for periods. And we do want to sometimes regulate periods for children who have different needs and different abilities. They may have significant cognitive delay or physical impairment where their caregivers cannot navigate periods appropriately. And so we can use birth control for menstrual suppression, and it works very well and improves their quality of life, certainly.
Gotcha.
Yeah.
Oh, I had another question for you. Oh, I wanted to ask you, I keep jumping
Mhm.
in between all their questions. I wanted to
That's
ask
okay.
you about girls or people who start their periods early.
Mhm.
Because I know that I'm not sure what the term is, but I do know that there are concerns, or that's a thing.
Mhm.
Could you just talk about
Yes.
that? Like people who start
So
their periods very young, like 9.
absolutely. So there's a term called precocious puberty, which it really
Mhm.
encompasses all of those things where you're kind of getting breast development early, pubic hair and underarm hair early, and even starting your periods early. So actually, the normal range for starting your period is age 9 to 15. And so people think
Mhm.
9 is too early, and it isn't anymore. It's not considered too early anymore. But with precocious puberty, if you're starting puberty too early, when you have that kind of endogenous or your body is releasing estrogen, we worry about a few things. We worry about where the source of that estrogen is, because sometimes it can be a cancer. It can be a malignancy that's releasing estrogen, and that's kind of scary. It can also be a disorder called McCune-Albright syndrome, which is just a particular kind of more common cause, I suppose, of precocious puberty, and that needs to be treated as well, because when you have release of estrogen, it closes the epiphyseal plates of the bones and actually stops you from growing. And so these girls can be like 4'2" if you start your puberty too early. And so we can give medication to suppress that, and then work with endocrinologists to give growth hormone to overcome that. And so it's a pretty big
Gotcha.
deal.
Right. Absolutely. Well,
Mhm.
those are all of the questions that I have. Those are the questions that we got from the audience. And I just want to
Awesome.
thank you so, so much for coming on. This was so informative, and it was quite lovely. It was quite lovely. So
Oh,
thank you.
listen,
And
thank you for having me. I appreciate you. I appreciate your time. I appreciate Slate for allowing us to do this.
likewise. And so tell us where to find you. The Period Doctor, IG and Twitter. Tell us where to find you.
Yes. So I'm at the Period Doctor on Instagram, at the Period Doctor on Twitter, and then you can go to my website at ThePeriodDoctor.com, and that's where you can look at some of my posts and even have kind of booking information for speaking engagements, of course, mostly virtual events as well.
All right, awesome. Well, thank you again, and thank you to everyone who tuned in and watched. I actually lied to y'all earlier. We are not coming back next week, but we will be back August 10th to talk to someone else. I need a break too, and I forgot that I get one next week.
You deserve it.
All right, thank you. All right, take care, y'all.